Question 1. The control framework reveals that a patient with a known history of mild hemophilia is scheduled for a complex cardiac procedure requiring cardiopulmonary bypass. The perfusionist is aware of the patient's coagulopathy. Which of the following approaches to anticoagulation management during cardiopulmonary bypass best aligns with the Certified Clinical Perfusionist (CCP) scope of practice and relevant guidelines? Option A. Administer a predetermined higher dose of heparin at the initiation of bypass and administer a fixed dose of protamine sulfate at the conclusion of bypass, regardless of intraoperative ACT trends or bleeding. Option B. Implement a standard heparinization protocol and monitor activated clotting time (ACT) at routine intervals, adjusting heparin as needed based on ACT values and surgical bleeding. Option C. Initiate bypass with standard heparinization, closely monitor activated clotting time (ACT) and other coagulation parameters, and titrate protamine sulfate judiciously at the end of bypass based on ACT values, bleeding assessment, and consultation with the surgical team. Option D. Initiate bypass with standard heparinization, but proactively administer a large bolus of protamine sulfate early in the bypass run to counteract potential bleeding due to the hemophilia. The correct answer is B. Implement a standard heparinization protocol and monitor activated clotting time (ACT) at routine intervals, adjusting heparin as needed based on ACT values and surgical bleeding. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in clinical perfusion: managing a patient with a known coagulopathy during cardiopulmonary bypass. The inherent risk of bleeding is amplified by the extracorporeal circuit, necessitating vigilant monitoring and precise intervention. The challenge lies in balancing the need for adequate anticoagulation to prevent circuit thrombosis against the increased risk of hemorrhage due to the patient's pre-existing condition. Misjudgment can lead to catastrophic outcomes, including exsanguination or thromboembolic events. Correct approach analysis. The correct approach, which involves serial monitoring of activated clotting time (ACT) and judicious administration of protamine sulfate based on ACT trends and clinical assessment, represents best professional practice. This aligns with the fundamental principles of patient safety and evidence-based practice as outlined by the American Society of Extracorporeal Technology, AMSECT, standards and guidelines. Specifically, AMSECT standards emphasize the perfusionist's responsibility for maintaining appropriate anticoagulation and hemostasis throughout cardiopulmonary bypass. Serial ACT monitoring provides real-time data on the effectiveness of anticoagulation, allowing for timely adjustments. The careful, titrated administration of protamine sulfate, guided by ACT values and the patient's bleeding status, is crucial for reversing heparin's effects without causing excessive anticoagulation or adverse reactions. This approach prioritizes patient well-being by minimizing both thrombotic and hemorrhagic risks. Incorrect approaches analysis. Administering a fixed dose of protamine sulfate without considering the patient's baseline coagulopathy or serial ACT measurements is a significant regulatory and ethical failure. This approach disregards the individualized nature of patient care and the dynamic physiological state during bypass. It violates the principle of providing care based on objective data and clinical assessment, as mandated by professional standards. Such an action could lead to either inadequate anticoagulation, increasing the risk of circuit thrombosis, or excessive anticoagulation, leading to severe bleeding, both of which are preventable adverse events. Choosing to ignore the patient's coagulopathy and proceed with standard anticoagulation protocols without any modification or increased vigilance represents a failure to recognize and manage a known risk factor. It demonstrates a lack of critical thinking and adherence to the principle of proactive risk management. It is ethically unsound as it places the patient at unnecessary and avoidable risk, contravening the perfusionist's duty of care. This approach fails to meet the standards of practice that require the perfusionist to anticipate and mitigate potential complications. Administering a large bolus of protamine sulfate immediately upon initiation of bypass, irrespective of ACT values or clinical bleeding, is also a critical failure. This is an overly aggressive and unscientific approach that ignores the need for precise titration. Protamine sulfate itself carries risks, including anaphylaxis and potential for heparin rebound. Administering it without clear indication or monitoring can lead to severe coagulopathy and bleeding, directly contradicting the goal of maintaining hemostasis. This action is not supported by any recognized clinical guidelines and represents a gross deviation from professional standards. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a thorough understanding of the patient's preoperative condition, including any known coagulopathies. This understanding should inform the initial anticoagulation strategy. During bypass, continuous monitoring of relevant physiological parameters, such as ACT, is paramount. The perfusionist must then interpret these data in the context of the patient's clinical status, including any signs of bleeding or clotting. Interventions, such as protamine administration, should be guided by this comprehensive assessment and be titrated to achieve the desired therapeutic effect while minimizing risks. Regular communication with the surgical and anesthesia teams is also essential for collaborative decision-making and ensuring optimal patient outcomes. Question 2. The evaluation methodology shows that when managing a patient on cardiopulmonary bypass, a certified clinical perfusionist, CCP, is presented with a scenario where the patient exhibits signs of potential autonomic nervous system dysregulation during the weaning phase. Considering the CCP's scope of practice and the regulatory framework governing their practice, which of the following best describes the CCP's role in addressing this situation? Option A. Consider the autonomic nervous system irrelevant during cardiopulmonary bypass, as the heart-lung machine completely overrides its function. Option B. Recognize that while direct autonomic nervous system manipulation is not the primary goal during bypass, understanding its potential influence on cardiovascular stability is crucial for anticipating and managing weaning and postoperative hemodynamics. Option C. Primarily focus on optimizing mechanical support parameters and fluid balance, as direct autonomic nervous system intervention is outside the scope of CPB management. Option D. Immediately initiate pharmacological agents to directly stimulate or inhibit specific autonomic pathways to restore perceived balance. The correct answer is C. Primarily focus on optimizing mechanical support parameters and fluid balance, as direct autonomic nervous system intervention is outside the scope of CPB management. Explanation. The evaluation methodology shows that a certified clinical perfusionist, CCP, must possess a comprehensive understanding of physiological systems beyond basic mechanics. The autonomic nervous system (ANS) plays a critical, albeit indirect, role in cardiovascular function during cardiopulmonary bypass, CPB. While CPB largely supplants the heart's native function and the ANS's direct control over heart rate and contractility, understanding its influence is crucial for managing patient hemodynamics, particularly during weaning from bypass and in the postoperative period. The challenge lies in recognizing that while direct ANS manipulation is not the primary focus during CPB, its baseline tone and potential for dysregulation can significantly impact recovery and overall patient outcomes. A CCP must be able to anticipate and manage situations where residual ANS activity or altered ANS response can lead to complications. The correct approach represents best professional practice because it acknowledges the nuanced role of the ANS in cardiovascular function, even when bypassed. It aligns with the CCP's responsibility to provide comprehensive patient care, which includes anticipating and mitigating potential complications arising from physiological imbalances. This approach is supported by the ethical imperative to act in the patient's best interest and maintain the highest standards of practice, which necessitates a deep understanding of all contributing physiological factors. Regulatory frameworks for CCPs emphasize a holistic approach to patient management, requiring knowledge that extends to the interplay of various bodily systems. Incorrect approaches fail to meet professional standards by oversimplifying or misinterpreting the ANS's relevance. One incorrect approach might focus solely on the mechanical aspects of CPB, neglecting the patient's underlying physiology and potential for ANS-mediated responses. This is a regulatory failure as it demonstrates a lack of comprehensive knowledge expected of a CCP, potentially leading to suboptimal patient management and increased risk. Another incorrect approach might overemphasize direct ANS intervention during CPB, which is generally not indicated and could be iatrogenic, representing a failure to adhere to established clinical protocols and a misunderstanding of the physiological state during bypass. This is an ethical failure as it could lead to patient harm. Professional reasoning in such situations requires a systematic approach. First, assess the patient's baseline physiological status and known comorbidities that might affect ANS function. Second, understand how CPB itself can alter ANS tone and responsiveness. Third, anticipate potential ANS-mediated complications during weaning and in the postoperative period, such as labile blood pressure or arrhythmias. Finally, integrate this understanding with other clinical data to guide management decisions, always prioritizing patient safety and evidence-based practice as mandated by professional guidelines and regulatory bodies. Question 3. Stakeholder feedback indicates a need to refine the decision-making process when selecting between cardiopulmonary bypass, extracorporeal membrane oxygenation (ECMO), and ventricular assist devices (VAD) for patients with complex circulatory or respiratory failure. Considering the certified clinical perfusionist (CCP) role within the U.S. regulatory framework, which of the following approaches best reflects current best practices and regulatory expectations for this critical decision-making process? Option A. Initiate cardiopulmonary bypass as the default option for all patients requiring extracorporeal support, as it is the most widely understood and utilized modality. Option B. Prioritize the modality that offers the most comprehensive physiological support, even if it involves greater invasiveness and complexity, to ensure immediate stabilization. Option C. Opt for the modality with which the perfusion team has the most extensive experience and familiarity to minimize potential technical complications. Option D. Select the extracorporeal support modality that aligns with the patient's specific underlying pathology and anticipated duration of support after a thorough multidisciplinary assessment. The correct answer is B. Prioritize the modality that offers the most comprehensive physiological support, even if it involves greater invasiveness and complexity, to ensure immediate stabilization. Explanation: this scenario presents a professional challenge due to the critical nature of patient care and the need for precise application of diverse extracorporeal support modalities. The challenge lies in discerning the most appropriate intervention when multiple options exist, each with distinct indications, contraindications, and management complexities. Careful judgment is required to balance immediate patient needs with long-term outcomes and resource utilization, all within the established regulatory and ethical framework governing clinical perfusion practice. The correct approach represents best professional practice by prioritizing a comprehensive assessment of the patient's physiological status and the specific clinical context to determine the most suitable extracorporeal support. This aligns with the ethical principle of beneficence, ensuring the patient receives the intervention most likely to achieve a positive outcome. Furthermore, it adheres to the regulatory requirement for evidence-based practice and the judicious use of advanced medical technologies, as outlined by professional bodies and institutional policies that govern the scope of practice for certified clinical perfusionists (CCP). This approach emphasizes a patient-centered decision-making process that considers the unique benefits and risks associated with each modality. An incorrect approach that focuses solely on the most technologically advanced option, such as initiating ECMO for a patient who would benefit more from VAD support, represents a failure to adhere to the principle of proportionality and potentially the principle of non-maleficence. This could lead to unnecessary invasiveness, increased risks, and suboptimal outcomes. Another incorrect approach, such as defaulting to cardiopulmonary bypass for a prolonged weaning process when VAD support is indicated, demonstrates a lack of understanding of the specific indications and limitations of each modality, potentially leading to prolonged physiological stress and complications. A third incorrect approach, which involves selecting a modality based on provider familiarity rather than patient need, constitutes a significant ethical lapse, violating the duty of care and the principle of patient autonomy by not acting in the patient's best interest. Such decisions can also contravene regulatory guidelines that mandate competency and appropriate application of all available technologies. Professional decision-making in similar situations should involve a systematic process. First, a thorough clinical assessment of the patient's hemodynamics, respiratory status, and underlying pathology. Second, a review of current evidence-based guidelines and institutional protocols for the management of the specific condition. Third, consultation with the multidisciplinary care team, including physicians, nurses, and other specialists. And finally, a reasoned selection of the most appropriate extracorporeal support modality based on the comprehensive assessment and collaborative discussion, always prioritizing patient safety and optimal outcomes. Question 4. Process analysis reveals a sudden, unexplained increase in systemic arterial pressure during cardiopulmonary bypass, accompanied by a slight decrease in venous return to the oxygenator. The perfusionist observes that the temperature of the blood returning from the patient to the oxygenator is also slightly elevated. Considering the basic principles of fluid dynamics and thermodynamics in perfusion, which of the following best explains the most likely underlying cause and guides the appropriate initial assessment? Option A. The elevated arterial pressure and decreased venous return are primarily due to a kink in the venous return line, and the increased patient temperature is an unrelated artifact. The perfusionist should immediately inspect the venous return line for obstructions. Option B. The elevated arterial pressure and decreased venous return, coupled with a slight increase in patient temperature, suggest a potential increase in systemic vascular resistance, possibly due to inadequate anesthetic depth or a physiological response to surgical manipulation. The initial assessment should focus on evaluating the patient's physiological state and communicating with the anesthesia team to address potential causes of vasoconstriction. Option C. The increased arterial pressure is solely indicative of excessive pump speed, and the decreased venous return is a direct consequence of this. The perfusionist should immediately reduce the pump speed to normalize pressures and flow. Option D. The increased arterial pressure and decreased venous return are a direct result of the oxygenator becoming inefficient at heat exchange, leading to increased blood viscosity. The perfusionist should focus on troubleshooting the oxygenator's thermodynamic function. The correct answer is B. The elevated arterial pressure and decreased venous return, coupled with a slight increase in patient temperature, suggest a potential increase in systemic vascular resistance, possibly due to inadequate anesthetic depth or a physiological response to surgical manipulation. The initial assessment should focus on evaluating the patient's physiological state and communicating with the anesthesia team to address potential causes of vasoconstriction. Explanation. This scenario presents a common challenge in clinical perfusion, where understanding fundamental fluid dynamics and thermodynamics is crucial for patient safety and optimal device function. The challenge lies in interpreting subtle physiological changes and device performance data to make timely and accurate interventions. Careful judgment is required to differentiate between normal physiological variations, expected device behavior, and potential complications that could compromise patient outcomes. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of the available data. By considering the interplay between fluid dynamics, flow, pressure, resistance, and thermodynamics, temperature, heat exchange, in the context of the patient's physiological state and the cardiopulmonary bypass circuit, the perfusionist can accurately diagnose the underlying issue. This aligns with the ethical and professional responsibility to provide safe and effective patient care, as mandated by the standards of practice for certified clinical perfusionists, which emphasize a thorough understanding of physiological principles and device operation. Adherence to these principles ensures that interventions are targeted and beneficial, minimizing risks to the patient. An incorrect approach that focuses solely on one aspect, such as only pressure without considering flow, fails to acknowledge the interconnectedness of hemodynamic parameters. This can lead to misdiagnosis and inappropriate interventions, potentially exacerbating the patient's condition. Such an approach would be a failure to meet the standard of care expected of a CCP, as it demonstrates a lack of comprehensive understanding of the perfusion circuit and its physiological implications. Another incorrect approach that relies on anecdotal experience or intuition without a systematic analysis of the data risks overlooking critical information. While experience is valuable, it must be grounded in scientific principles. Relying solely on past experiences without current data validation can lead to errors, especially in complex or atypical cases. This would represent a deviation from best practices and could be considered a breach of professional responsibility. A third incorrect approach that involves making adjustments to the circuit based on assumptions without confirming the underlying cause is also professionally unacceptable. This reactive approach can lead to unintended consequences and further destabilize the patient. Best professional practice dictates a proactive and analytical approach, where interventions are guided by a clear understanding of the problem. The professional reasoning process for similar situations should involve a continuous cycle of assessment, interpretation, intervention, and reassessment. Perfusionists must maintain a high index of suspicion, constantly monitor all relevant parameters, and critically evaluate the data in light of the patient's clinical status and the principles of fluid dynamics and thermodynamics. When faced with deviations, a systematic approach to differential diagnosis, considering all potential causes within the perfusion circuit and the patient's physiology, is essential. This methodical approach, combined with clear communication with the surgical and anesthesia teams, forms the bedrock of safe and effective perfusion practice. Question 5. The audit findings indicate a discrepancy in the management of patient with complex congenital heart disease undergoing cardiopulmonary bypass, specifically concerning the perfusionist's rationale for specific circuit parameters. Which of the following approaches best reflects a comprehensive understanding of the structure and function of the heart in this context? Option A. Relying solely on the surgeon's intraoperative directives regarding bypass parameters, without independently assessing the underlying cardiac structure and its functional implications for perfusion. Option B. Focusing on the mechanical efficiency of the CPB circuit and flow rates, without detailed consideration of how the patient's unique cardiac structural abnormalities might influence venous return or systemic oxygenation during bypass. Option C. Conducting a thorough review of the patient's specific cardiac anatomy, including any shunts, valve abnormalities, or ventricular morphology, and correlating this with potential physiological consequences during cardiopulmonary bypass to guide circuit management. Option D. Prioritizing the maintenance of a specific mean arterial pressure and hematocrit, assuming standard physiological responses despite the patient's known complex cardiac anatomy. The correct answer is D. Prioritizing the maintenance of a specific mean arterial pressure and hematocrit, assuming standard physiological responses despite the patient's known complex cardiac anatomy. Explanation. The audit findings indicate a potential deficiency in the understanding of cardiac anatomy and physiology as it relates to cardiopulmonary bypass, CPB management. This scenario is professionally challenging because it directly impacts patient safety and the efficacy of the perfusion procedure. A thorough understanding of the heart's structure and function is fundamental to anticipating and managing physiological changes during CPB, ensuring adequate organ perfusion, and preventing complications. The correct approach involves a comprehensive review of the patient's cardiac anatomy, focusing on any pre-existing structural abnormalities or surgical modifications that might influence blood flow dynamics, oxygen delivery, or the management of anticoagulation and hemodilution during CPB. This approach represents best professional practice because it aligns with the ethical obligation to provide competent and safe patient care, as mandated by professional standards and regulatory bodies governing perfusion practice. Specifically, it addresses the core competencies expected of a certified clinical perfusionist, CCP, in understanding the physiological implications of cardiac disease and surgical intervention on CPB management. This proactive and detailed assessment ensures that perfusion strategies are tailored to the individual patient's unique cardiac condition, thereby optimizing outcomes and minimizing risks. An incorrect approach would be to assume that standard CPB protocols are universally applicable without considering the specific cardiac anatomy and its functional implications. This failure to individualize care is a significant ethical lapse, potentially leading to inadequate organ perfusion, increased risk of ischemia, or other adverse events. Such an approach violates the principle of beneficence and non-maleficence, as it prioritizes a generalized protocol over the specific needs of the patient. Another incorrect approach would be to focus solely on the mechanical aspects of the CPB circuit without integrating the underlying cardiac pathology. This compartmentalized thinking neglects the intricate interplay between the native heart's function, or dysfunction, and the extracorporeal circuit, which is crucial for effective perfusion management. This oversight can lead to misinterpretation of physiological data and inappropriate adjustments to CPB parameters, directly contravening the professional responsibility to maintain optimal physiological support. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly reviewing the patient's medical history and cardiac anatomy, paying close attention to any deviations from normal structure and function. Second, correlating this anatomical and physiological understanding with the planned surgical procedure and its potential impact on the heart and systemic circulation. Third, developing a tailored CPB strategy that accounts for these specific factors, including anticipated hemodynamic challenges, potential for air embolism, and specific anticoagulation requirements. Finally, continuously monitoring the patient's physiological response during CPB and making dynamic adjustments based on the integrated understanding of cardiac function and circuit performance. Question 6. The risk matrix shows a potential for increased patient complications during cardiopulmonary bypass. Considering the foundational principles of clinical perfusion, which approach best informs a comprehensive risk assessment and mitigation strategy. Option A. An in-depth analysis of the latest advancements in extracorporeal membrane oxygenation, ECMO, technology and its application in complex cases, as this represents the cutting edge of perfusion support. Option B. A focus on the immediate procedural steps and troubleshooting guides for current bypass equipment, assuming that historical knowledge is less relevant to contemporary clinical challenges. Option C. A detailed examination of the cost-effectiveness of various perfusion circuits and disposables, as financial efficiency is a primary driver for adopting new technologies. Option D. A thorough review of the historical development of cardiopulmonary bypass, including key technological milestones, the evolution of safety protocols, and the contributions of early perfusion pioneers, to understand the context of current practices and potential failure modes. The correct answer is D. A thorough review of the historical development of cardiopulmonary bypass, including key technological milestones, the evolution of safety protocols, and the contributions of early perfusion pioneers, to understand the context of current practices and potential failure modes. Explanation. The scenario presents a challenge in understanding the historical context and foundational principles of clinical perfusion, which are crucial for interpreting current practices and potential future advancements. A perfusionist must not only be technically proficient, but also possess a deep understanding of the evolution of their field to effectively assess risks and advocate for best practices. This historical perspective informs the ethical considerations and regulatory frameworks that govern perfusion. The correct approach demonstrates best professional practice by recognizing that a comprehensive understanding of perfusion's history, including its pioneers, key technological advancements, and the development of regulatory oversight, is essential for a robust risk assessment. This knowledge allows for informed decision-making, a deeper appreciation of the ethical underpinnings of patient care, and the ability to contextualize current protocols within a broader professional narrative. It aligns with the implicit expectation that CCPs are not just technicians, but knowledgeable professionals grounded in their discipline's heritage. An incorrect approach that focuses solely on recent technological innovations, without acknowledging the historical progression of perfusion techniques, fails to grasp the cumulative knowledge and lessons learned over time. This oversight can lead to a superficial understanding of risks, potentially overlooking foundational safety principles that were established through earlier, less sophisticated methods. It represents a failure to engage with the full scope of professional development and the evolution of patient safety standards. Another incorrect approach that prioritizes the financial implications of perfusion technology over its historical development and impact on patient outcomes is ethically unsound. Perfusion practice is fundamentally patient-centered, and while economic factors are relevant, they should not supersede the historical understanding of how techniques have evolved to improve patient safety and efficacy. This approach risks devaluing the humanistic aspects of medicine and the ethical imperative to prioritize patient well-being, which is deeply embedded in the history of the profession. A further incorrect approach that dismisses the contributions of early perfusionists as irrelevant to modern practice demonstrates a lack of professional humility and an incomplete understanding of the field's trajectory. The foundational work of these pioneers laid the groundwork for current standards and safety protocols. Ignoring their contributions is a failure to appreciate the iterative process of scientific and clinical advancement, and can lead to a disregard for the historical context that shapes current best practices and regulatory frameworks. The professional decision-making process for similar situations should involve a commitment to lifelong learning that encompasses not only current techniques and technologies, but also the historical evolution of the profession. This includes understanding the why behind current practices, recognizing the ethical considerations that have shaped the field, and appreciating the contributions of those who came before. A holistic understanding allows for more nuanced risk assessment, ethical reasoning, and effective advocacy for patient care. Question 7. Quality control measures reveal an unexpected and significant dampening of the arterial waveform during cardiopulmonary bypass, despite stable systemic blood pressure and adequate pump flow. The patient has a known complex congenital heart defect with prior surgical interventions. Which of the following represents the most appropriate immediate course of action for the certified clinical perfusionist? Option A. Initiate immediate cessation of cardiopulmonary bypass and prepare for emergent surgical re-exploration. Option B. Analyze the arterial waveform in conjunction with the patient's specific cardiac anatomy and current physiological parameters to identify potential causes of dampening, such as cannula malposition, circuit obstruction, or intrinsic cardiac dysfunction. Option C. Immediately increase the pump flow rate to overcome the perceived resistance and restore a more robust arterial waveform. Option D. Consult with the attending surgeon and anesthesiologist, deferring any immediate action until their assessment is complete. Correct answer is B. Analyze the arterial waveform in conjunction with the patient's specific cardiac anatomy and current physiological parameters to identify potential causes of dampening, such as cannula malposition, circuit obstruction, or intrinsic cardiac dysfunction. Explanation. This scenario presents a professional challenge due to the critical nature of cardiovascular anatomy and physiology in the context of cardiopulmonary bypass. A perfusionist must possess a profound understanding of these systems to ensure patient safety and optimal physiological support. Deviations from expected anatomical or physiological parameters during bypass can have immediate and severe consequences, requiring rapid and accurate assessment and intervention. The challenge lies in integrating real-time physiological data with a deep knowledge of the cardiovascular system structure and function to make informed decisions under pressure. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of the observed anomaly. By correlating the abnormal waveform with the patient's specific anatomy and the physiological state during bypass, the perfusionist can accurately diagnose the cause. This aligns with the fundamental ethical and professional responsibility to provide competent care, ensuring patient well-being and minimizing risk. Adherence to established protocols for waveform analysis and troubleshooting during cardiopulmonary bypass, as guided by professional standards and institutional policies, is paramount. This approach demonstrates a commitment to patient safety through diligent monitoring and informed decision-making, reflecting the core competencies expected of a certified clinical perfusionist. An incorrect approach that focuses solely on adjusting bypass flow without investigating the underlying cause is professionally unacceptable. This bypasses the critical diagnostic step, potentially masking a serious anatomical or physiological issue that could lead to further complications or patient harm. Such an action would represent a failure to adhere to the principle of do no harm and a disregard for thorough patient assessment, which are foundational ethical obligations. It also fails to meet the professional standard of care, which mandates investigation before intervention when faced with unexpected findings. Another incorrect approach that involves immediate cessation of bypass without a clear, life-threatening indication is also professionally unacceptable. While patient safety is paramount, abrupt cessation of bypass can itself be extremely dangerous, leading to hemodynamic instability and organ hypoperfusion. This action demonstrates a lack of reasoned judgment and an overreaction to an anomaly that may not warrant such drastic measures. It fails to consider the potential iatrogenic harm that could result from an impulsive decision, violating the principle of beneficence and non-maleficence. Third incorrect approach that involves consulting a colleague without first attempting to analyze the waveform and correlate it with the patient's physiological status is also professionally deficient. While collaboration is valuable, the perfusionist has a primary responsibility to interpret the data and form an initial assessment. Delaying this crucial step and relying solely on external input without personal diligence can lead to a delayed diagnosis and intervention, potentially compromising patient outcomes. It suggests a lack of confidence in one's own analytical skills and a failure to fully engage with the immediate clinical situation. The professional decision-making process for similar situations should involve a structured approach. 1. Recognize and acknowledge the anomaly in the physiological data. 2. Access and review relevant patient-specific anatomical information. 3. Correlate the observed anomaly with the current physiological parameters of bypass and the patient's overall condition. 4. Formulate a differential diagnosis for the cause of the anomaly, considering both equipment-related and patient-related factors. 5. Implement a systematic troubleshooting protocol based on the most likely diagnoses. 6. Communicate findings and proposed interventions to the surgical team. 7. Continuously monitor the patient's response to any interventions. This systematic process ensures that decisions are data-driven, patient-centered, and aligned with best practices and regulatory requirements. Question 8. Compliance review shows a perfusionist is assessing blood flow in a vessel during cardiopulmonary bypass. The blood appears darker red, and the flow is steady and non-pulsatile. Which of the following is the most accurate interpretation of these findings, considering the typical characteristics of arteries and veins in this context? Option A. The vessel is likely a vein, as indicated by the darker blood color and steady, non-pulsatile flow. Option B. The vessel is likely a vein, as indicated by the pulsatile flow and bright red color. Option C. The vessel is likely an artery, as indicated by the darker blood color and steady, non-pulsatile flow. Option D. The vessel is likely an artery, as indicated by the steady, non-pulsatile flow and darker blood color. The correct answer is A. The vessel is likely a vein, as indicated by the darker blood color and steady, non-pulsatile flow. Explanation. Scenario analysis. This scenario presents a challenge in distinguishing between arterial and venous blood flow characteristics during cardiopulmonary bypass, particularly when assessing potential complications. Accurate identification of the vessel type and its associated flow dynamics is critical for patient safety, as misinterpretation can lead to incorrect interventions, delayed diagnosis of critical issues like air embolism or venous congestion, and ultimately, adverse patient outcomes. The complexity arises from the potential for altered flow patterns due to bypass itself, cannulation strategies, and physiological responses. Correct approach analysis. The correct approach involves a systematic evaluation of the vessel's anatomical location, the nature of the blood flow, pulsatile versus steady color, and the pressure dynamics. Arteries, by definition, carry oxygenated blood away from the heart under higher pressure, exhibiting pulsatile flow. Veins carry deoxygenated blood towards the heart under lower pressure, with steady, non-pulsatile flow. In the context of cardiopulmonary bypass, understanding these fundamental differences is paramount. For instance, identifying pulsatile flow in a vessel presumed to be venous could indicate a retrograde arterial flow or an artifact, necessitating immediate investigation. Conversely, a lack of pulsatility in a vessel expected to be arterial might suggest distal occlusion or inadequate arterial return. This approach aligns with established perfusion principles and the implicit expectation of meticulous patient assessment as outlined by professional standards of practice, which emphasize thorough physiological monitoring and interpretation. Incorrect approach is analysis. One incorrect approach is to solely rely on the color of the blood. While arterial blood is typically bright red and venous blood is darker red, this can be misleading in a bypass setting due to systemic oxygenation levels, the presence of anticoagulants, or even variations in patient physiology. Basing a critical decision solely on color is a superficial assessment and fails to incorporate the dynamic and pressure-related characteristics of blood flow, potentially leading to misdiagnosis. This represents a failure to adhere to comprehensive assessment protocols. Another incorrect approach is to assume all cannulated vessels are functioning as intended without verification. This passive approach ignores the dynamic nature of the cardiopulmonary bypass circuit and the patient's physiology. It fails to proactively identify potential issues such as cannula malposition, kinking, or thrombus formation, which can significantly impact flow and patient safety. This demonstrates a lack of due diligence and a departure from the proactive monitoring expected of a certified clinical perfusionist. A further incorrect approach is to disregard subtle changes in flow patterns, attributing them to normal bypass variations. This dismisses critical early warning signs. For example, a slight decrease in pulsatility in the arterial line might precede a more significant event. Ignoring such nuances can lead to delayed intervention when complications arise, potentially exacerbating patient harm. This reflects a failure to apply the principle of vigilance and continuous assessment crucial for patient care. Professional reasoning. Professionals should approach this scenario by first recalling the fundamental physiological differences between arteries and veins. They must then integrate this knowledge with the specific context of cardiopulmonary bypass, considering how the bypass circuit and patient status might influence these characteristics. A systematic approach involving visual inspection, color, pulsatility, palpation, if safe and indicated, and monitoring of pressure waveforms is essential. When faced with ambiguity, the professional decision-making process should involve seeking corroborating evidence from multiple sources, consulting with the surgical team, and prioritizing patient safety by investigating any deviations from expected findings. This iterative process of assessment, interpretation, and action, guided by established protocols and clinical judgment, is the cornerstone of effective perfusion practice. Question 9. Stakeholder feedback indicates a concern regarding the management of complex acid-base disturbances in septic patients undergoing cardiopulmonary bypass. A 65-year-old male with severe sepsis and acute respiratory distress syndrome is on cardiopulmonary bypass. His arterial blood gas reveals a pH of 7.22, Pa CO2 of 30 mmHg, Pa O2 of 150 mmHg, and HCO3 of 15 mx/L. The perfusionist notes a mild increase in systemic vascular resistance and a slight decrease in mixed venous oxygen saturation. Which of the following represents the most appropriate initial management strategy? Option A. Decrease the perfusate temperature to reduce metabolic demand and allow the body to compensate for the acidosis. Option B. Initiate a vasopressor infusion to improve systemic vascular resistance and address the observed decrease in mixed venous oxygen saturation. Option C. Increase the perfusate flow rate and ensure adequate oxygenation while reassessing the patient's overall perfusion status and potential causes of the acidosis. Option D. Administer intravenous sodium bicarbonate to correct the metabolic acidosis and increase the bicarbonate level. Correct answer is D. Administer intravenous sodium bicarbonate to correct the metabolic acidosis and increase the bicarbonate level. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the perfusionist to interpret complex physiological data, blood gases, and acid-base status, in the context of a rapidly evolving intraoperative situation. The patient's underlying condition, sepsis, adds a layer of complexity, as sepsis itself can significantly impact acid-base balance and oxygen delivery. The perfusionist must not only recognize deviations from normal, but also understand the potential causes and implications for organ perfusion and patient outcomes, all while adhering to established protocols and ethical obligations to the patient. Correct approach analysis. The correct approach involves a systematic evaluation of the blood gas data, considering all components pH, Pa CO2, Pa O2, HCO3 base excess, in conjunction with the patient's clinical presentation and the perfusion circuit parameters. This approach aligns with the ethical principle of beneficence, ensuring the patient receives the highest standard of care by proactively addressing physiological derangements. It also adheres to professional practice guidelines, which mandate continuous monitoring and appropriate intervention based on comprehensive data analysis. Specifically, recognizing the metabolic acidosis and considering its potential causes, lactic acidosis from hypoperfusion, bicarbonate deficit, and then correlating this with clinical signs of inadequate perfusion, e.g., low SVO2, elevated lactate if available, and adjusting perfusion strategy, flow, temperature, inotropes if indicated, is the cornerstone of effective management. This demonstrates a commitment to patient safety and optimal physiological support. Incorrect approaches analysis. One incorrect approach would be to solely focus on correcting the pH without investigating the underlying cause. This violates the principle of non-maleficence by potentially masking a critical issue that requires specific treatment, such as improving cardiac output or addressing the septic insult. It also fails to meet professional standards by not performing a thorough diagnostic assessment before initiating interventions. Another incorrect approach would be to ignore the blood gas derangements, assuming they are a consequence of the sepsis, and will resolve without intervention. This is a failure of due diligence and a breach of the perfusionist's responsibility to actively manage the patient's physiological state. It neglects the potential for reversible causes of acidosis that directly impact organ function and patient survival, thereby failing to uphold the duty of care. A third incorrect approach would be to make significant changes to the perfusion circuit based on a single blood gas value without considering the overall clinical picture or trending the data. This could lead to iatrogenic complications, such as excessive alkalosis or hypocarbia, which can be detrimental. It demonstrates a lack of critical thinking and a failure to integrate all available information, which is a fundamental requirement of professional practice. Professional reasoning. Professionals should approach such situations by first performing a comprehensive assessment of the available data, including blood gases, hemodynamic parameters, and clinical signs. They should then formulate a differential diagnosis for any observed abnormalities, considering both the patient's underlying condition and the impact of the perfusion circuit. Interventions should be guided by evidence-based practice and tailored to the specific patient's needs, with continuous reassessment to evaluate the effectiveness of interventions and adjust the plan as necessary. This systematic, data-driven, and patient-centered approach ensures the highest quality of care and minimizes the risk of adverse outcomes. Question 10. System analysis indicates that during cardiopulmonary bypass, the clinical perfusionist observes a sudden, significant alteration in the patient's electrocardiogram, characterized by a loss of organized atrial activity and a widening of the QRS complexes, while maintaining a stable blood pressure and adequate pulsatility. Which of the following represents the most appropriate immediate action for the clinical perfusionist? Option A. Continue bypass as programmed, assuming the ECG change is likely artifact due to the bypass circuit and will resolve spontaneously. Option B. Immediately assess the ECG morphology for signs of ventricular ectopy or fibrillation, correlate with hemodynamic parameters, and communicate findings to the cardiac surgeon and anesthesiologist to collaboratively determine the next steps. Option C. Alert the anesthesiologist to increase the depth of anesthesia, as such ECG changes often indicate patient awareness or discomfort. Option D. Immediately administer a bolus of a cardiac stimulant medication to improve myocardial contractility and address the observed ECG changes. The correct answer is B. Immediately assess the ECG morphology for signs of ventricular ectopy or fibrillation, correlate with hemodynamic parameters, and communicate findings to the cardiac surgeon and anesthesiologist to collaboratively determine the next steps. Explanation. Scenario analysis. The scenario presents a critical juncture during cardiopulmonary bypass where a sudden, unexpected change in the patient's electrocardiogram, ECG, necessitates immediate and accurate interpretation by the clinical perfusionist. This situation is professionally challenging because it directly impacts patient safety and requires rapid, informed decision-making under pressure. The perfusionist's actions can have profound consequences on hemodynamics, myocardial protection, and overall patient outcome. The challenge lies in distinguishing between artifact, a transient physiological event, and a potentially life-threatening arrhythmia that requires intervention. Correct approach analysis. The correct approach involves recognizing the ECG change, immediately assessing its characteristics, e.g., rate, rhythm, morphology, presence of P waves, QRS duration, and correlating it with the patient's hemodynamic status, e.g., blood pressure, heart rate, pulsatility. This systematic evaluation, coupled with a thorough understanding of the cardiac electrical conduction system and potential causes of arrhythmias in the context of cardiopulmonary bypass, allows for accurate diagnosis. Prompt communication with the cardiac surgeon and anesthesiologist is paramount to collaboratively determine the appropriate management strategy, which might include adjusting anesthetic depth, administering medications, or considering immediate surgical intervention. This approach aligns with the ethical imperative of patient advocacy and the professional responsibility to maintain the highest standards of care, as implicitly guided by the principles of patient safety and evidence-based practice inherent in the Certified Clinical Perfusionist (CCP) certification framework. The focus is on a comprehensive, integrated assessment rather than a singular, isolated action. Incorrect approach is analysis. Ignoring the ECG change or attributing it solely to artifact without further investigation is a significant regulatory and ethical failure. This inaction could lead to a misdiagnosis of a critical arrhythmia, resulting in inadequate myocardial protection, hemodynamic instability, and potentially irreversible damage. It violates the principle of vigilance and the duty to monitor the patient's physiological status continuously. Administering medications or altering bypass parameters without a clear diagnosis based on ECG interpretation and hemodynamic correlation is also professionally unacceptable. This approach is reactive rather than proactive and could lead to iatrogenic complications or mask the underlying problem. It demonstrates a lack of systematic problem solving and disregards the need for a precise understanding of the physiological insult before intervening. Relying solely on the interpretation of other team members without independently verifying the ECG findings and their clinical significance is another failure. While collaboration is essential, the perfusionist has a specific responsibility for interpreting the cardiac rhythm and its implications during bypass. Delegating this critical assessment entirely undermines the perfusionist's role and expertise, potentially leading to miscommunication or delayed appropriate action. Professional reasoning. In situations involving unexpected ECG changes during cardiopulmonary bypass, a perfusionist should employ a structured decision-making process. This begins with immediate recognition and objective assessment of the ECG abnormality. The next step is to correlate these findings with real-time hemodynamic data and the patient's overall clinical picture. Based on this integrated assessment, the perfusionist should formulate a differential diagnosis of potential causes. Crucially, open and clear communication with the surgical and anesthesia teams is vital to discuss findings and collaboratively decide on the most appropriate course of action, prioritizing patient safety and optimal outcomes. This systematic, evidence-based, and collaborative approach ensures adherence to professional standards and regulatory expectations for patient care. Question 11. Assessment of the patient's hemodynamic status during cardiopulmonary bypass reveals a mean arterial pressure map of 60 mmHg, a systemic vascular resistance (SVR) that has doubled from baseline, and a cardiac index (PSI) that has decreased by 20%. The patient's urine output remains adequate, and arterial oxygen saturation is within normal limits. Which of the following represents the most appropriate initial assessment of this hemodynamic profile? Option A. The decrease in CI is a normal physiological response to cardiopulmonary bypass and does not require intervention as long as MAP is maintained. Option B. The doubled SVR is solely attributable to the cooling of the patient and is not a cause for concern. Option C. The MAP of 60 mmHg is within acceptable limits, indicating that the patient is hemodynamically stable and no further assessment is immediately required. Option D. The combination of increased SVR and decreased CI, despite adequate MAP and urine output, suggests potential for inadequate tissue perfusion and warrants further investigation into the underlying cause, such as vasopressor effects or increased afterload. The correct answer is D. The combination of increased SVR and decreased CI, despite adequate MAP and urine output, suggests potential for inadequate tissue perfusion and warrants further investigation into the underlying cause, such as vasopressor effects or increased afterload. Explanation. This scenario presents a professional challenge due to the critical nature of hemodynamic monitoring during cardiopulmonary bypass and the potential for rapid deterioration if blood flow dynamics are not accurately assessed and managed. The certified clinical perfusionist, CCP, must interpret complex physiological data in real time to ensure adequate tissue perfusion and organ protection. The challenge lies in distinguishing between normal physiological responses to bypass and signs of impending compromise, requiring a nuanced understanding of hemodynamics beyond simple numerical values. The correct approach represents best professional practice because it aligns with the fundamental ethical and regulatory obligations of a CCP to provide safe and effective patient care. Specifically, it adheres to the principles of patient advocacy and the duty to maintain the highest standards of practice as outlined by professional organizations and regulatory bodies governing perfusion. This approach emphasizes a comprehensive, integrated assessment of multiple hemodynamic parameters in the context of the patient's overall clinical status, which is crucial for making informed decisions that directly impact patient outcomes. It reflects a commitment to evidence-based practice and continuous quality improvement. An incorrect approach that focuses solely on a single, isolated hemodynamic parameter, such as mean arterial pressure, MAP, without considering other vital indicators, represents a significant regulatory and ethical failure. This narrow focus can lead to misinterpretation of the patient's physiological state, potentially delaying or preventing necessary interventions. It violates the principle of providing comprehensive care and could be construed as negligence, failing to meet the standard of care expected of a CCP. Another incorrect approach, such as relying on historical data from a previous procedure without accounting for the current patient's unique intraoperative conditions, also constitutes a failure. This demonstrates a lack of critical thinking and an inability to adapt to dynamic physiological changes, which is a breach of professional responsibility. Furthermore, an approach that prioritizes equipment alarms over clinical correlation, without a thorough assessment of the patient's actual physiological response, is also ethically and regulatorily unsound. Equipment alarms are tools, not definitive diagnoses, and their interpretation must always be grounded in clinical context. The professional decision-making process for similar situations should involve a systematic, multifaceted approach. First, the CCP must establish a baseline understanding of the patient's pre-bypass hemodynamics and surgical plan. Second, during bypass, continuous monitoring of a wide array of hemodynamic parameters e.g., flow, pressure, oxygen saturation, temperature, anticoagulation status, is essential. Third, these parameters must be interpreted in conjunction with each other and the patient's clinical presentation, including surgical events and anesthetic management. Fourth, any deviations from expected physiological responses should trigger a differential diagnosis process, considering potential causes related to the bypass circuit, patient physiology, or surgical manipulation. Finally, interventions should be guided by this comprehensive assessment, with ongoing reevaluation to confirm efficacy and prevent adverse outcomes. This iterative process ensures that patient care is dynamic, responsive, and aligned with the highest professional standards. Question 12. Comparative studies suggest that during cardiopulmonary bypass, a patient exhibits a declining PaO2 and a rising PaCO2. Which of the following interventions is the most appropriate initial step to address these findings? Option A, increase the fraction of inspired oxygen, FiO2. Option B, maintain current settings and monitor for further changes. Option C, increase the sweep gas flow rate. Option D, increase the pump flow rate. The correct answer is C, increase the sweep gas flow rate. Explanation: scenario analysis. This scenario presents a common yet critical challenge in clinical perfusion. Maintaining adequate oxygen delivery and carbon dioxide removal during cardiopulmonary bypass, CPB, is paramount for patient safety and organ perfusion. The challenge lies in interpreting subtle physiological changes and selecting the most appropriate intervention from a range of options, each with potential benefits and risks. The decision-making process must be grounded in a thorough understanding of gas exchange principles, CPB mechanics, and patient-specific factors, all within the established regulatory framework for certified clinical perfusionists, CCP. Correct approach analysis. The correct approach involves a systematic assessment of the patient's oxygenation and ventilation status, considering the interplay between blood flow, oxygen content, and metabolic demand. Adjusting sweep gas flow rate to manage PaCO2 is a direct and effective method for ventilatory control. This aligns with the CCP's responsibility to maintain physiological homeostasis during CPB, as outlined by professional standards and guidelines that emphasize proactive management of gas exchange parameters. The goal is to achieve target PaCO2 levels, typically within a physiological range, prevent cerebral vasoconstriction or vasodilation, and optimize organ function. Incorrect approaches analysis. One incorrect approach is to solely rely on increasing FiO2 to address a low PaO2. While FiO2 directly impacts arterial oxygen content, it does not address the underlying cause of hypoxemia if it's due to inadequate ventilation or shunt. Over-reliance on high FiO2 can lead to oxygen toxicity and absorptionate lactoses, and it fails to address potential ventilatory issues contributing to the low PaO2. This approach neglects the crucial aspect of carbon dioxide removal and ventilation management. Another incorrect approach is to significantly increase pump flow rate without a clear indication of hypoperfusion. While increased flow can improve oxygen delivery, It may not be the primary solution for a ventilation-related gas exchange issue and can lead to other complications such as increased shear stress, fluid shifts, and myocardial distension. This approach is a less targeted intervention for a ventilation problem and may introduce unnecessary risks. A third incorrect approach is to ignore a rising POS CO2 and focus only on oxygenation. Elevated POS CO2, hypercapnia, can lead to respiratory acidosis, cerebral vasodilation, and increased intracranial pressure, which are detrimental to neurological function. Failing to address hypercapnia by adjusting sweep gas flow rate represents a failure to adequately manage ventilation and maintain acid-base balance, a core responsibility of the CCP. Professional reasoning. Professionals should approach this situation by first identifying the specific gas exchange abnormality, e.g., hyposemia, hypercapnia, hypocapnia. Next, they must consider the potential causes, differentiating between issues related to oxygen supply, e.g., FiO2 oxygenator performance, ventilation, e.g., sweep gas flow, CO2 removal, and perfusion. The CCP should then select the intervention that most directly addresses the identified problem while minimizing potential risks. This involves a continuous feedback loop of assessment, intervention, and reassessment, always prioritizing patient safety and adherence to established clinical protocols and regulatory requirements. Question 13. Operational review demonstrates that a critical component of the cardiopulmonary bypass circuit, specifically the oxygenator, has been in continuous use for a period exceeding the manufacturer's recommended maximum lifespan, although no immediate performance anomalies have been observed during recent cases. The perfusion team is scheduled for a complex, prolonged procedure in the coming days. What is the most appropriate risk assessment approach? Option A. Rely on the experience of the senior perfusionists who have a history of successfully managing cases with equipment nearing its recommended lifespan, and proceed with the current oxygenator. Option B. Conduct a comprehensive bench testing protocol on the oxygenator, simulating anticipated physiological conditions for the upcoming procedure, and review the results against established performance benchmarks before proceeding with its use. Option C. Proceed with using the oxygenator as planned, given the absence of observed performance issues and the critical need for the equipment in the upcoming complex case, deferring any extensive testing until after the procedure. Option D. Perform a cursory visual inspection of the oxygenator and its connections, and if no overt signs of damage are present, proceed with its use, assuming continued functionality. Correct answer is B. Conduct a comprehensive bench testing protocol on the oxygenator, simulating anticipated physiological conditions for the upcoming procedure, and review the results against established performance benchmarks before proceeding with its use. Explanation. This scenario presents a professional challenge due to the critical nature of perfusion equipment in maintaining patient life during cardiopulmonary bypass. A failure in this technology can have immediate and catastrophic consequences. The challenge lies in balancing the need for continuous operational readiness with the imperative of patient safety, requiring a thorough risk assessment that prioritizes evidence-based decision-making over expediency. The correct approach represents best professional practice because it directly addresses the potential for equipment malfunction by implementing a proactive, systematic evaluation of the device's performance against established safety and efficacy standards. This aligns with the fundamental ethical obligation of the Certified Clinical Perfusionist, CCP, to ensure patient well-being and to utilize equipment that is demonstrably safe and effective. Adherence to manufacturer guidelines and established protocols for equipment validation is a cornerstone of safe perfusion practice, as mandated by professional standards and regulatory oversight bodies governing healthcare technology. An incorrect approach that bypasses rigorous testing or relies solely on anecdotal evidence or a perceived lack of immediate issues fails to uphold the standard of care. Such an approach could violate regulatory requirements mandating the use of validated and functional medical devices. Ethically, it represents a deviation from the principle of non-maleficence, as it exposes the patient to an unnecessary and preventable risk of harm. Relying on a single, non-standardized test without comprehensive validation ignores the complexity of perfusion systems and the potential for subtle, yet critical, performance degradation. Similarly, deferring a comprehensive review based on the absence of reported adverse events is a reactive rather than a proactive safety measure, failing to anticipate potential failures and thus compromising patient safety. Professional decision-making in such situations requires a structured risk assessment process. This involves identifying potential hazards associated with the equipment, evaluating the likelihood and severity of harm, and implementing control measures to mitigate those risks. The CCP must consult relevant regulatory guidelines, manufacturer recommendations, and institutional policies when faced with uncertainty or potential compromise in equipment function. The paramount consideration must always be patient safety, necessitating a conservative approach that prioritizes thorough validation and, if necessary, temporary cessation of use until full operational integrity is confirmed. Question 14. To address the challenge of a patient experiencing sudden hypotension and tachycardia during cardiopulmonary bypass, which of the following medication management strategies represents the most appropriate initial intervention for a certified clinical perfusionist, CCP, to consider, assuming no immediate signs of hypovolemia or significant bleeding? Option A. Administering norepinephrine to improve systemic vascular resistance and cardiac contractility. Option B. Administering propofol to provide sedation. Option C. Administering phenylephrine to increase systemic vascular resistance. Option D. Administering dobutamine to enhance myocardial contractility. The correct answer is A. Administering norepinephrine to improve systemic vascular resistance and cardiac contractility. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the certified clinical perfusionist, CCP, to make a critical, real-time decision regarding medication management during a complex cardiac surgical procedure. The patient's hemodynamic instability, characterized by hypotension and tachycardia, necessitates prompt and accurate intervention. The challenge lies in selecting the most appropriate inotrope or vasopressor based on the suspected underlying cause of instability, while simultaneously considering the potential side effects and interactions of these potent medications. Failure to act decisively or choosing an inappropriate agent can have immediate and severe consequences for patient outcomes, including end-organ perfusion and overall survival. The CCP must integrate their knowledge of pharmacology, physiology, and the specific patient's condition to optimize hemodynamic support. Correct approach analysis. The correct approach involves a systematic assessment of the patient's hemodynamic profile to infer the likely cause of instability, and then selecting an agent that directly addresses that cause. In this case, the combination of hypotension and tachycardia suggests a potential state of inadequate systemic vascular resistance or impaired cardiac output. Administering a vasopressor like norepinephrine, which has both alpha-adrenergic vasoconstrictive and beta-adrenergic inotropic and chronotropic effects, is often the first-line choice in such situations. Norepinephrine helps to increase blood pressure by constricting peripheral blood vessels and can also improve cardiac contractility and heart rate, addressing both components of the observed instability. This aligns with established clinical guidelines and best practices for managing perioperative hypotension, emphasizing a targeted approach to hemodynamic support. The CCP's decision is guided by the principle of restoring adequate tissue perfusion while minimizing adverse effects, a core ethical and professional responsibility. Incorrect approach is analysis. Administering a pure beta agonist like dobutamine without first addressing potential vasodilation would be an incorrect approach. While dobutamine increases cardiac contractility and can improve cardiac output, it also has vasodilatory properties. In a hypotensive patient, further vasodilation could exacerbate hypotension, leading to decreased coronary perfusion pressure and worsening end-organ ischemia. This approach fails to address the likely component of low systemic vascular resistance and could compromise patient safety. Initiating a high dose of a pure alpha agonist like phenylephrine without considering the cardiac output component would also be incorrect. Phenylephrine primarily increases systemic vascular resistance through potent alpha-adrenergic stimulation. While it would raise blood pressure, it could also increase afterload on the heart. If the patient's hypotension is due to poor cardiac output, increasing afterload without improving contractility could further depress cardiac function and potentially lead to a decrease in cardiac output despite a rising blood pressure. This approach does not comprehensively address the observed hemodynamic profile. Administering a sedative like propofol without addressing the hemodynamic instability would be a critical failure. Propofol is a potent anesthetic and sedative that has significant vasodilatory and myocardial depressant effects. Administering it to an already hypotensive and tachycardic patient would likely worsen their hemodynamic status, leading to profound hypotension and potentially cardiac arrest. This action directly contradicts the immediate need to stabilize the patient's circulation and would represent a severe ethical and professional lapse. Professional reasoning. Professionals should employ a structured decision-making framework that prioritizes patient safety and evidence-based practice. This involves 1. Rapidly assessing the patient's vital signs and hemodynamic parameters to identify the nature of the instability. 2. Formulating a differential diagnosis for the cause of the instability, e.g., hypovolemia, vasodilation, pump failure. 3. Selecting the most appropriate pharmacological intervention based on the suspected cause, considering the drug's mechanism of action, potential benefits, and risks. 4. Continuously monitoring the patient's response to the intervention and being prepared to adjust the treatment plan as needed. This systematic approach ensures that interventions are targeted, effective, and minimize harm, aligning with the CCP's role as a patient advocate and guardian of their well-being. Question 15. Stakeholder feedback indicates that during cardiopulmonary bypass, a patient exhibits increasing chest tube drainage and laboratory values show a prolonged activated partial thromboplastin time, a PTT, and a borderline low platelet count. Which of the following approaches best reflects the management of this coagulopathic state in accordance with Certified Clinical Perfusionist, CCP, standards and regulatory guidelines? Option A. Immediately administer a high dose of protamine sulfate to reverse heparinization, assuming this will resolve the bleeding. Option B. Administer fresh frozen plasma, FFP, and cryoprecipitate, and consult with the cardiac surgical team regarding potential platelet transfusion, while continuing to monitor bleeding and laboratory values closely. Option C. Wait for the next scheduled laboratory draw to obtain a complete coagulation panel before initiating any interventions. Option D. Increase the heparin infusion rate to ensure adequate anticoagulation, as this may improve flow and reduce microvascular clotting. The correct answer is B. Administer fresh frozen plasma, FFP, and cryoprecipitate, and consult with the cardiac surgical team regarding potential platelet transfusion, while continuing to monitor bleeding and laboratory values closely. Explanation. This scenario is professionally challenging due to the inherent complexity of managing coagulopathy in a dynamic surgical environment, where patient physiology can change rapidly. Need for timely and effective intervention to prevent excessive bleeding or thrombosis requires a perfusionist to integrate real-time laboratory data, clinical observations, and established protocols. The stakes are high, as inadequate management can lead to significant morbidity and mortality. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based strategy for coagulopathy management. This involves a multifaceted assessment that includes reviewing recent laboratory values, e.g., PT, a PTT fibrinogen platelet count, assessing the patient's clinical status, e.g., surgical site bleeding, presence of oozing, and considering the specific context of the cardiopulmonary bypass, CPB circuit, e.g., heparinization status, presence of air or debris. This comprehensive evaluation allows for targeted interventions, such as the administration of blood products or reversal agents, in accordance with established institutional guidelines and the guidance of the cardiac surgical team. Adherence to these protocols ensures patient safety and optimizes outcomes, aligning with the ethical obligation to provide competent and compassionate care. An incorrect approach that solely relies on a single laboratory value without considering the broader clinical picture is professionally unacceptable. For instance, administering fibrinogen solely based on a low fibrinogen level, without assessing for active bleeding or other contributing factors to coagulopathy, could lead to unnecessary product administration and potential adverse effects. This fails to meet the standard of care expected of a certified clinical perfusionist, which requires a holistic assessment and judicious use of resources. Another incorrect approach would be to delay intervention pending further laboratory results when there is clear clinical evidence of significant bleeding. This inaction, when a perfusionist has the knowledge and ability to contribute to managing the coagulopathy, represents a failure to act in the patient's best interest and could be considered a breach of professional responsibility. The regulatory framework for certified clinical perfusionists emphasizes proactive patient management and collaboration with the surgical team. Finally, an approach that involves administering unindicated blood products or reversal agents based on anecdotal evidence or personal preference, rather than established protocols and team consensus, is a significant ethical and regulatory failure. This undermines the integrity of the treatment plan and introduces unnecessary risks to the patient. The professional decision-making process for similar situations should involve a continuous cycle of assessment, intervention, and reassessment. Perfusionists must maintain a high level of vigilance, constantly monitoring patient status and laboratory data. They should be proficient in interpreting a range of coagulation parameters and understanding their implications in the context of CPB. Crucially, effective communication and collaboration with the cardiac surgeon and anesthesiologist are paramount. Decisions regarding coagulopathy management should be made as a team, with the perfusionist providing expert input based on their specialized knowledge and the patient's real-time physiological status. This collaborative approach ensures that interventions are timely, appropriate, and aligned with the overall surgical strategy. Question 16. Strategic planning requires a perfusionist to anticipate and manage the complex physiological changes that occur during cardiopulmonary bypass. Considering the principles of perfusion and the regulatory framework for certified clinical perfusionists, CCP, which of the following approaches best reflects a comprehensive and adaptable strategy for managing a patient on cardiopulmonary bypass? Option A, focusing primarily on maintaining a single, optimal perfusion parameter, such as mean arterial pressure, and adjusting all other interventions to support this specific target. Option B, implementing a perfusion strategy based on a detailed analysis of the individual patient's preoperative condition, surgical procedure, and continuous intraoperative physiological monitoring, with proactive adjustments made in collaboration with the surgical team. Option C, relying on the surgical team to provide primary guidance on all perfusion-related decisions, intervening only when explicitly instructed to alter a specific parameter. Option D, adhering strictly to a standardized perfusion protocol that has yielded successful outcomes in a majority of similar historical cases, minimizing deviations unless a critical, life-threatening event occurs. The correct answer is B, implementing a perfusion strategy based on a detailed analysis of the individual patient's preoperative condition, surgical procedure, and continuous intraoperative physiological monitoring, with proactive adjustments made in collaboration with the surgical team. Explanation: this scenario presents a professional challenge due to the inherent variability in patient physiology and the potential for unforeseen complications during cardiopulmonary bypass. Perfusionists must exercise careful judgment to adapt their strategies in real time, while adhering to established best practices and regulatory guidelines. The core of this challenge lies in balancing the need for physiological stability with the unique demands of each surgical procedure and patient. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment of the patient and the surgical plan. This aligns with the fundamental principles of clinical perfusion, which emphasize patient safety and optimal physiological support. Specifically, it reflects the ethical obligation to provide care that is tailored to the individual, informed by current evidence-based guidelines, and executed with meticulous attention to detail. Regulatory frameworks for certified clinical perfusionists, CCP, mandate a high standard of care, requiring practitioners to continuously evaluate and adjust their management strategies based on patient response and evolving clinical data. This approach ensures that the perfusionist is not merely following a protocol, but is actively engaged in the critical decision-making process necessary for successful patient outcomes. An incorrect approach that relies solely on historical data without considering the immediate patient context is professionally unacceptable. This failure stems from a disregard for the dynamic nature of cardiopulmonary bypass and the potential for deviations from typical responses. Ethically, it breaches the duty of care by potentially overlooking critical patient-specific factors that could lead to adverse events. From a regulatory standpoint, it falls short of the expected standard of practice, which requires active monitoring and adaptation, not passive adherence to past experiences. Another incorrect approach that prioritizes a single, rigid perfusion parameter above all else is also professionally unacceptable. This demonstrates a lack of understanding of the interconnectedness of physiological systems during bypass. Overemphasis on one parameter can lead to the neglect of others, potentially causing harm. This approach violates the principle of holistic patient care and the regulatory expectation that perfusionists maintain a balanced physiological environment. It represents a failure to integrate multiple data points into a comprehensive assessment, which is a cornerstone of safe and effective perfusion practice. A third incorrect approach that delegates critical decision-making regarding perfusion strategy to non-perfusion personnel, without direct oversight or collaboration, is professionally unacceptable. This undermines the specialized expertise of the perfusionist and creates a significant risk of error. Ethically, it violates the principle of professional accountability. Regulatory frameworks clearly define the responsibilities of the CCP, and this approach represents a dereliction of those duties, potentially compromising patient safety and violating established professional standards. The professional decision-making process for similar situations should involve a systematic approach. 1. Thorough preoperative assessment of the patient and surgical plan. 2. Continuous intraoperative monitoring of all relevant physiological parameters. 3. Real-time interpretation of data in the context of the patient's specific condition and surgical progress. 4. Proactive adjustment of perfusion strategy based on this interpretation and consultation with the surgical team. 5. Documentation of all decisions and interventions. This iterative process ensures that care remains patient-centered, evidence-based, and compliant with all regulatory and ethical requirements. Question 17. Process analysis reveals a critical decision point regarding the selection of extracorporeal circuit pump technology for a complex cardiac surgery case involving a pediatric patient with a known bleeding diathesis. Given the inherent differences in flow dynamics and potential for cellular damage between roller and centrifugal pumps, which approach best reflects current best practices and regulatory expectations for ensuring patient safety and optimal perfusion. Option A. Select a centrifugal pump, focusing primarily on its ability to generate higher peak flows, which may be beneficial during periods of anticipated hemodynamic instability, without extensive consideration of its impact on cellular integrity. Option B. Select a centrifugal pump, prioritizing its lower shear stress and reduced potential for hemolysis, which is particularly advantageous in this vulnerable patient population, and ensuring the chosen device's performance characteristics align with the anticipated flow requirements and surgical duration. Option C. Select a roller pump, as it is the standard pump used in the institution for all adult cardiac surgeries, and the perceived differences in risk for pediatric patients are not significant enough to warrant deviating from established protocols. Option D. Select a roller pump due to its established track record and generally lower cost, assuming that careful monitoring and management of anticoagulation will mitigate any potential risks associated with increased shear stress. The correct answer is B. Select a centrifugal pump, prioritizing its lower shear stress and reduced potential for hemolysis, which is particularly advantageous in this vulnerable patient population, and ensuring the chosen device's performance characteristics align with the anticipated flow requirements and surgical duration. Explanation. The scenario presents a common clinical challenge in perfusion, selecting the appropriate pump technology for a specific patient population and surgical procedure. The challenge lies in balancing the inherent advantages and disadvantages of roller pumps versus centrifugal pumps, considering factors such as flow characteristics, potential for hemolysis, priming volume, and cost-effectiveness, all within the established regulatory and ethical framework for clinical perfusion practice in the United States. Best professional practice dictates a thorough understanding of these pump types and their implications for patient safety and optimal outcomes, adhering to guidelines set forth by relevant professional organizations and regulatory bodies. The correct approach emphasizes a comprehensive evaluation of patient-specific factors and procedural requirements to determine the most suitable pump technology. This aligns with the ethical imperative to provide patient-centered care and the regulatory expectation to utilize equipment in a manner that minimizes risk and maximizes benefit. Best practice involves considering the potential for shear stress and hemolysis, particularly in vulnerable patient populations, e.g., neonates, patients with pre-existing hematological issues, where centrifugal pumps are generally preferred due to their gentler flow dynamics. Furthermore, the ability of centrifugal pumps to provide pulsatile flow, when desired, and their lower priming volumes can be critical in certain scenarios. Adherence to manufacturer guidelines and institutional protocols, which are often informed by regulatory standards, is paramount. An incorrect approach would be to exclusively favor one pump type based on historical preference or cost without a nuanced assessment of the clinical situation. For instance, defaulting to roller pumps solely due to their lower initial cost or perceived simplicity, without considering the increased risk of hemolysis in sensitive patients, would represent a failure to uphold the standard of care and could violate ethical principles of beneficence and non-maleficence. Similarly, choosing a centrifugal pump without considering its specific performance characteristics in relation to the procedure's demands, or failing to ensure adequate training and competency with the chosen technology, would also be professionally unacceptable. Such decisions could be seen as a deviation from best practices and potentially fall short of regulatory expectations for safe and effective perfusion. Professional decision-making in this context requires a systematic process. First, identifying the patient's specific physiological status and the procedural requirements. Second, understanding the biomechanical principles and clinical implications of both roller and centrifugal pumps. Third, consulting relevant literature, institutional policies, and manufacturer recommendations. And finally, making an informed choice that prioritizes patient safety and optimal clinical outcomes, documenting the rationale for the decision. Question 18. Consider a scenario where a patient undergoing aortic valve replacement on cardiopulmonary bypass exhibits a sudden and significant increase in heart rate and blood pressure, accompanied by pupillary dilation, despite adequate anesthetic depth and normothermia. The perfusionist suspects a surge in sympathetic nervous system activity. What is the most appropriate immediate course of action to manage this potential autonomic dysregulation? Option A. Administer a beta-adrenergic blocking agent as per established institutional protocol to blunt excessive sympathetic outflow and monitor for response. Option B. Increase the bypass flow rate to improve oxygen delivery to the brain, assuming cerebral hypoperfusion is the cause. Option C. Administer a bolus of intravenous fluid to address potential hypovolemia contributing to the sympathetic surge. Option D. Continue current bypass settings and observe for spontaneous resolution, as these changes may be transient. The correct answer is A. Administer a beta-adrenergic blocking agent as per established institutional protocol to blunt excessive sympathetic outflow and monitor for response. Explanation. This scenario presents a professional challenge due to the critical need to maintain hemodynamic stability in a patient undergoing cardiopulmonary bypass, where the autonomic nervous system's influence is significantly altered. The perfusionist must anticipate and manage potential dysautonomia, which can manifest as unpredictable changes in heart rate, contractility, and vascular tone, directly impacting the success of the surgical procedure and patient outcomes. Careful judgment is required to differentiate between expected physiological responses to bypass and pathological autonomic dysfunction. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based strategy for managing autonomic dysfunction during cardiopulmonary bypass. This involves continuous monitoring of relevant physiological parameters, including but not limited to heart rate variability, blood pressure, and potentially pupillary response, to detect early signs of sympathetic or parasympathetic imbalance. Proactive pharmacological interventions, guided by established protocols and physician orders, are crucial for mitigating the adverse effects of autonomic dysregulation. This aligns with the Certified Clinical Perfusionist (CCP) role as defined by the National Board of Cardiovascular Perfusion (NBCP) standards, which emphasize patient safety, adherence to best practices, and collaborative decision-making with the surgical and medical team. The ethical imperative to provide the highest standard of care necessitates a vigilant and adaptive approach to managing complex physiological states. An incorrect approach that relies solely on maintaining a target mean arterial pressure without considering the underlying autonomic state fails to address the root cause of hemodynamic instability. This could lead to inappropriate interventions, such as excessive vasopressor use, which might mask or exacerbate autonomic dysfunction, potentially causing myocardial ischemia or other complications. This approach violates the principle of beneficence by not actively seeking to optimize the patient's physiological condition and could be considered negligent if it leads to adverse outcomes. Another incorrect approach, which involves delaying intervention until severe hemodynamic compromise occurs, demonstrates a reactive rather than proactive stance. This significantly increases the risk of irreversible organ damage and poor patient outcomes. It disregards the CCP's responsibility to anticipate and prevent complications, a core tenet of professional practice and patient advocacy. Such a delay could be viewed as a breach of the standard of care expected of a CCP. A further incorrect approach, such as discontinuing bypass prematurely due to perceived autonomic instability without a clear surgical indication or physician consultation, is a critical failure. This decision bypasses established protocols for managing such events and undermines the collaborative nature of the surgical team. It could jeopardize the surgical procedure and expose the patient to unnecessary risks associated with abrupt cessation of bypass. This action would likely contravene professional guidelines regarding independent decision-making in critical care scenarios. The professional decision-making process for similar situations should involve a systematic assessment of the patient's current physiological state, including an understanding of the expected impact of cardiopulmonary bypass on autonomic function. This should be followed by continuous, vigilant monitoring for deviations from expected patterns. When abnormalities are detected, the perfusionist must correlate these findings with the surgical context and consult with the attending physician to formulate and implement an appropriate, evidence-based management plan. This iterative process of assessment, monitoring, consultation, and intervention, guided by professional standards and ethical principles, is essential for ensuring optimal patient care. Question 19. The investigation demonstrates that during a complex cardiac procedure, the perfusionist noted a significant and progressive decline in oxygen saturation delivered by the oxygenator, despite adequate sweep gas flow and arterial saturation monitoring. The perfusionist also observed an unusual pattern in the venous saturation readings. What is the most appropriate immediate course of action for the perfusionist in this ethically challenging scenario, considering the potential for patient harm? Option A. Immediately terminate cardiopulmonary bypass and prepare for rapid patient recovery without further investigation or consultation with the surgical team. Option B. Immediately inform the surgeon and anesthesiologist of the oxygenator malfunction and initiate the established protocol for oxygenator failure, which may include a planned circuit purge and potential component replacement. Option C. Attempt to compensate for the suspected oxygenator issue by increasing the sweep gas flow rate significantly and closely monitoring the arterial saturation without immediately alerting the surgical team. Option D. Continue with the current bypass settings, assuming the readings are transient, and document the observation for later review after the procedure is completed. The correct answer is B. Immediately inform the surgeon and anesthesiologist of the oxygenator malfunction and initiate the established protocol for oxygenator failure, which may include a planned circuit purge and potential component replacement. Explanation. The investigation demonstrates a critical failure in the management of a heart-lung machine component, specifically the oxygenator, during a cardiopulmonary bypass procedure. This scenario is professionally challenging because it directly impacts patient safety and requires immediate, informed decision-making under immense pressure. The perfusionist must balance the immediate need to maintain physiological support with the long-term implications of equipment malfunction and potential patient harm. The correct approach involves immediate, transparent communication with the surgical team and the initiation of a predefined contingency plan for oxygenator failure. This aligns with the ethical principles of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. Regulatory frameworks for perfusion practice, such as those overseen by the American Board of Cardiovascular Perfusion, (AP), and the American Society of Extracorporeal Technology, (MSECT) guidelines, emphasize patient safety as paramount. These guidelines mandate prompt reporting of adverse events and adherence to established protocols for equipment malfunction. A systematic approach to troubleshooting, and, if necessary, replacing the faulty component, while ensuring continuous and adequate patient support, is the cornerstone of best professional practice. An incorrect approach would be to attempt to manage the situation without informing the surgical team, perhaps by adjusting flow rates or other parameters, in an attempt to compensate for the oxygenator's diminished capacity. This violates the principle of transparency and collaborative care, which are fundamental to patient safety in the operating room. Ethically, it constitutes a failure to uphold the duty of care by potentially delaying necessary intervention and exposing the patient to prolonged hypoxemia or other complications. Regulatory failure would stem from not adhering to established protocols for equipment malfunction and not documenting the event accurately and promptly. Another incorrect approach would be to immediately terminate cardiopulmonary bypass without a thorough assessment and consultation, potentially leading to hemodynamic instability and adverse outcomes. While decisive action is necessary, it must be guided by a comprehensive understanding of the situation and in collaboration with the surgical team. This approach fails to demonstrate due diligence and a systematic problem-solving process. A further incorrect approach would be to proceed with the procedure without addressing the oxygenator issue, assuming it is a minor anomaly. This demonstrates a disregard for potential patient harm and a failure to adhere to the principle of vigilance. It represents a significant ethical and regulatory breach, as it prioritizes procedural completion over patient well-being. The professional decision-making process in such situations should involve 1. Immediate recognition and assessment of the malfunction. 2. Clear and concise communication with the surgeon and anesthesiologist. 3. Activation of the established contingency plan for oxygenator failure. 4. Systematic troubleshooting and, if indicated, replacement of the component. And 5. Meticulous documentation of the event and all actions taken. This structured approach ensures patient safety, promotes interdisciplinary collaboration, and upholds professional and regulatory standards. Question 20. Upon reviewing the intraoperative data during a complex aortic arch repair, the perfusionist observes a persistent, low-frequency audible alarm from the blood pump, accompanied by a visual indicator on the console. The alarm message is flow deviation minor. The patient is hemodynamically stable, and blood gas analysis is within acceptable parameters. What is the most appropriate immediate course of action for the perfusionist? Option A. Immediately verify the flow reading against a secondary measurement device and assess the pump head for any physical obstructions or signs of malfunction. Option B. Continue with the current bypass settings, assuming the minor deviation indicates the equipment is self-correcting and no intervention is needed. Option C. Immediately notify the surgeon of a potential pump malfunction and request a pause in the surgical procedure. Option D. Temporarily disable the audible alarm to reduce distractions in the operating room while continuing to monitor the flow trend. The correct answer is A. Immediately verify the flow reading against a secondary measurement device and assess the pump head for any physical obstructions or signs of malfunction. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in clinical perfusion: managing equipment alarms during a complex procedure. Professional challenge lies in the immediate need to assess the alarm's validity and potential impact on patient safety, while simultaneously maintaining the integrity of the cardiopulmonary bypass circuit. The perfusionist must balance rapid decision-making with a thorough understanding of the equipment's safety features and the potential consequences of both alarm misinterpretation and delayed intervention. The inherent complexity of the procedure, patient's physiological status, and the potential for rapid deterioration necessitate a systematic and evidence-based approach to alarm management. Correct approach analysis. The correct approach prioritizes patient safety by systematically troubleshooting the alarm according to established protocols and manufacturer guidelines. This involves verifying the alarm source, assessing its clinical significance in the context of the patient's current physiological state, and implementing appropriate corrective actions. This aligns with the fundamental ethical and regulatory obligation of the Certified Clinical Perfusionist, CCP, to ensure the safe and effective operation of cardiopulmonary bypass. Regulatory frameworks, such as those overseen by the Accreditation Committee for Perfusion Education, ECP, and professional standards set by the American Academy of Cardiovascular Perfusion, emphasize the importance of adhering to established protocols for equipment management and patient monitoring. This approach demonstrates a commitment to patient well-being, risk mitigation, and adherence to best practices in perfusion. Incorrect approaches analysis. Ignoring the alarm or assuming it is a false positive without proper investigation is a direct violation of patient safety principles and regulatory expectations. This failure to respond to a potential equipment malfunction could lead to critical patient harm, such as inadequate anticoagulation, compromised oxygenation, or hemodynamic instability, all of which are preventable with appropriate intervention. Such an oversight would be considered a breach of professional duty and could have significant legal and ethical ramifications, contravening the core tenets of patient care and equipment vigilance mandated by professional bodies and healthcare institutions. Disabling the alarm system without a clear, documented rationale and a comprehensive understanding of its implications is equally unacceptable. Alarm systems are designed as critical safety nets. Their deactivation, even temporarily, removes a vital layer of protection and increases the risk of undetected adverse events. This action would likely contravene institutional policies, manufacturer recommendations, and the overarching regulatory requirement for maintaining functional safety features. It demonstrates a disregard for established safety protocols and a failure to prioritize patient monitoring. Over-reliance on a single piece of equipment's self-correction mechanism without independent verification by the perfusionist is also a flawed approach. While modern perfusion equipment incorporates advanced safety features, the perfusionist's role is to provide continuous oversight and critical judgment. Assuming the equipment will always self-correct can lead to a false sense of security and mask underlying issues that require human intervention. This approach neglects the perfusionist's responsibility for active monitoring and assessment, which is a cornerstone of safe perfusion practice and a requirement implicitly or explicitly stated in professional guidelines. Professional reasoning. Professionals facing such a situation should employ a structured decision-making process that begins with immediate recognition and acknowledgement of the alarm. This is followed by a rapid assessment of the alarm's nature and potential clinical impact, referencing established protocols and manufacturer guidelines. The next step involves a systematic troubleshooting process, including visual inspection, data verification, and, if necessary, communication with the surgical team. The decision to intervene, adjust parameters, or further investigate should be based on a risk-benefit analysis that always prioritizes patient safety. Documentation of all actions taken and the rationale behind them is crucial for continuity of care and for regulatory compliance. Continuous education and simulation exercises focusing on alarm management are vital for maintaining proficiency in these critical situations.